our next topic and our next presenter is Dr. Alex de Rosario, who I'm very proud to have speak. Those of you who know Alex, I mean, he's very well known among the HIV treater community, both in LA and here. Alex, I think you've had a longer track almost than I have in all these places. Dr. de Rosario went did his undergraduate in physiology at the University of California at Berkeley and attended medical school at good old-fashioned Hahnemann in Philadelphia. And he completed his residency of internal medicine at California Pacific. And he's really one of the leaders in HIV care, both here at the Coachella Valley and throughout the United States. So speaking about hypogonadism in people with HIV is Dr. Alex de Rosario.
Thank you. Hi. So I'm Alex de Rosario. I'm actually one of the medical directors of one of our new Lemley Lamelli clinic here in Palm Springs. And I've got about 1,000 HIV positive patients under my care, plus another 1,200 HIV negative guys. And here in the Coachella Valley, my practice is 95% gay male. So that's the population I deal with. So we're going to talk about something that is very common among our HIV positive patients is testosterone replacement therapy and testosterone usage. A lot of you practitioners may have patients that come to you already on testosterone replacement therapy. I have no financial disclosures. And so we're going to go straight in here because we're going to try to get to the meat of the talk is going to be management of testosterone and the pitfalls of with it. So HIV is not directly toxic to the Leydig cells of the testicles. There are no CD4 receptors, CCR5 receptors, or anything on the Leydig cells. So what we think the reason why HIV causes low testosterone is because of the inflammatory condition that Dr. Latender had talked about. In particular, some of these cytokines, interleukin 1 beta, IL-6, and tumor necrosis factor. This inflammatory milieu in the testes and also in the brain affect testosterone production. So in the testicles, they decrease steroidogenesis in the Leydig cells, and in the brain, they affect the pulsatile release of the hormones in the pituitary gland and in the hypothalamus and the pituitary gland, causing the hypothalamus and the pituitary to be unresponsive to low levels of testosterone. So commonly what you see is in someone who has low testosterone is that their luteinizing hormones are inappropriately normal. So, as far as the low testosterone levels are very common. This is from some of the MAX data. These were men who were at risk for HIV and men who were HIV positive. For every point value, when they took a look at over time, HIV positive men have lower testosterone levels than men who are at risk for HIV. And it's not the fact that the testosterone levels decline faster, it's just for every point in time, they're lower than HIV negative men. I'm gonna go quickly because we're gonna get to the management stuff. So symptoms of low testosterone, we're all very familiar with them. Lethargy, fatigue, decreased stamina, decreased energy. These are all sort of amorphous symptoms and sort of difficult to pin down as far as ways to measure them, but they have a big impact on the lives of HIV positive men who've been positive for a long time and have low testosterone levels. So decrease in body habit, a change in body habits, they lose their lean muscle, they increase subcutaneous body fat. One of the things that is a little easier sometimes to pin down is that, again, guys notice that they're losing their body hair, axillary, pubic, and hair over the body. Those are all symptoms of low testosterone, and these will all get better if you replace testosterone. So as far as diagnosing the type of testosterone you're looking for, the method you're using, and the time of day you're testing makes a difference. So as far as the types of testosterone, a lot of labs, some places, they'll just check for the total testosterone. That is the total amount of testosterone, including the bound and unbound. When we talk about bound testosterone, most of testosterone, 60% is bound to sex hormone binding globulin. That is considered an unavailable testosterone because it's tightly bound. The loosely bound is bound to albumin. That's about 37 to 38%. And then the free testosterone is just a very small amount. That is the testosterone that is not bound, that can actually bind to the testosterone receptor and actually do its job. So that's actually one of the things that the more important ones to measure. And when we talk about bioavailable testosterone, that is testosterone that is weakly bound to albumin and the free testosterone. So that's what we mean by bioavailable testosterone. And then other factors that affect the testosterone, this binding, there's a whole bunch of things that increase the sex hormone binding globulin. Physiologic aging is the big one here in our patient population. As you get older, you secrete more sex hormone binding globulin that makes less testosterone available. You have less free testosterone. There are some things here which increase sex hormone, which can decrease sex hormone binding globulin and make more testosterone available. The problem is some of these conditions can exist in the same patient. So the effect on sex hormone binding globulin is a little difficult to pin down. So that's why it's better to measure both the free and the total testosterone. And then the method matters and how you're going to measure this. So the gold standard for measuring testosterone is something called liquid chromatography dual mass spectroscopy. That is the best method. That's the type of way you should be measuring your testosterone because this is the most accurate. It is the most specific. It only measures the testosterone. The other methods can overlap with other hormones. It's a complex test, so not all labs do this. And it's also costly to perform, so it tends to be more expensive. Your institution you're at may prefer using the less expensive method, which is also less accurate at low testosterone. That's the immunoassay method. This is the more common way of measuring testosterone, but it is also the least accurate method. It's faster, it's more cost effective, it can be run by a machine. No human has to intervene. This is all run by a machine, so it's very efficient, but it is less accurate, especially at low testosterones. And the low testosterone number it gives can have as much as a 2 to a 14-fold variation because it is so inaccurate at low testosterone levels. So particularly in testing testosterone levels in women and children, in men on androgen deprivation therapy, and in the population we're interested in is hypogonadism men who have low testosterone, we're going to get a less accurate testosterone measurement if you use the immunoassay. So you should use the liquid chromatography dual mass spectroscopy method. And then again, the more common, the cheaper, more effective one, or more easily used one, is also less effective because there's interference from similar steroids like DHEA, other steroids, cortisol also interfere with that. So it tends to give you an overestimate of what the testosterone is because of the interfering substances. And then time of day when you measure testosterone matters because this graph shows you on the top graph there is young healthy men, young healthy being 20 to 30, and the older men, and to me, older men is anyone older than me, but it is average age 71. So you can see there's a diurnal variation of the testosterone there. There's most testosterone, you can't see these numbers, is high in the morning. So typically when you measure testosterone, endocrinologists will tell you measure it in the morning between 8 and 10 a.m. Because if that testosterone is low, then everything else is going to be lower for that reason. And if you follow the American Urologic Association guidelines, they're recommending testosterone replacement if their testosterone level is less than 300 nanograms per deciliter. But what is the problem is that sometimes in labs, what they say is a low testosterone is less than 200, 250, or 240 nanograms per deciliter. So what do you do with a guy when you get a number that says 275 nanograms per deciliter? The American Urological Association says, go ahead and give them testosterone. But their insurance would say, no, they're not going to get testosterone because they're not technically lower. What do? You measure it later in the day because it's going to be lower later in the day. Okay. There. And in older men, that diurnal variation is less active. So in our patient population, we're concerned about it's somewhere in between those two. So discussing the pros and cons of testosterone replacement, you are not meant to read the slide. This is my dot phrase in EPIC, my dot phrase, which says, this is what I discuss with patients. It's a long discussion because there's a lot of pros and cons you got to talk about. So if you have a macro or dot phrase, it helps to put all this stuff in there. So we're going to go over some of this. And when you do have the discussion of testosterone replacement with your patients, usually the tendencies you're going to talk about all the pros and all the cons. When I've done that, if you get to the con list, they sort of tune you out and they're not going to listen to you anymore. So I mix up my pros and cons. And the pros tend to be sort of more, like we said, ethereal as far as increased energy, stamina. It's harder for us clinicians to measure that. The cons tend to be more significant and serious. And so that sometimes if you talk them all together, the patient sounds like to them that you're trying to talk them out of testosterone replacement therapy when you want to just say, let's have a discussion about what the pros and cons are. So testosterone increases all secondary male sexual characteristics. The first question I usually ask my patients is, how attached are you to the hair on your head? Because we're going to make it go away. And that sometimes ends the discussion right there. They don't want the hair to go away, but it enhances all secondary male sexual characteristics. It increases body hair. So we say we're gonna make you furrier everywhere except the top of your head. You're gonna get hairier everywhere. And you know, you would think for some people, if they said, "Oh, I don't want to lose my hair," they look like me. It's like, I don't care about losing my hair. I want the effects of testosterone. It's going to increase the libido. That's the side effect we're after. This is very dose dependent. So the delivery mechanism matters for this. So the ones that deliver less testosterone, less of an increase. The ones that deliver more testosterone, more of an increase. But we're going to talk about the problems with that. And that's, again, dose dependent on that. And they may be limited by other underlying factors. Us as clinicians, this is the part we have to pay attention to and moderate the patient's expectations. So many studies have shown if they have symptoms of anxiety, symptoms of depression, those get better with testosterone replacement. But if they actually have clinical depression, if they meet the criteria for clinical depression and are antidepressant medications, the improvement in their libido is going to be much less impressive, and there may not be much of an improvement. So if your patient is on 3 or 4 antidepressant medications for major depression, and they're wanting their testosterone replacement to improve their libido, you might not be getting much of a response out of that. But if they just have symptoms of depression, symptoms of anxiety, that will get better. As far as the potential for increase in aggression, this was sort of a very interesting study that it sometimes depends on other things too. So they actually took one of the studies took a look at men who were in a low stress state, had low cortisol levels, and were given testosterone. They tended to be more aggressive and competitive against men they perceived to be higher social status, sort of knocking the king off the hill. But if you gave testosterone to someone who had a higher cortisol level, a higher stress state, they tended to be aggressive and compete against men who they perceived to be lower status, so kicking the puny off the hill. So it depends on other things, what the testosterone affects their aggressivity. And then as far as increase in appetite, they're going to eat more. So depending on what their body habit it is, they can get really famished, hungry on testosterone, and you got to watch what they're eating and make sure they eat the right things. This is the reason why bodybuilders love testosterone. It increases lean muscle mass and it decreases subcutaneous fat. So guys really benefit from this because it improves their energy, their stamina, their endurance. Testosterone increases apocrine sweat secretions. So men are going to smell more manly ripe on testosterone. This is also dose dependent. The more testosterone you give them, the more manly ripe they're going to smell. The quick way I tell patients about this, you're going to look like a man, you're going to act like a man, you're going to eat like a man, you're going to smell like a man. And they get that. So they say, I just want to feel more like being a man, because the reason they're coming in to see you is because they don't feel very masculine because their testosterone levels are low. You can fix all of these things and they're going to be happy about that, but you're also going to talk about some of the downsides. As far as some things that's sometimes unrecognized, testosterone will bring out sleep apnea. So for whatever reason, testosterone causes the muscles of the throat to relax and collapse. Increased muscularity in men causes the throat to collapse. And because testosterone will increase their lean muscle mass, their body mass index will go up. If they're if they're in the 220-pound club, they're likely going to have sleep apnea. So these are one of the things you got to be able to look for. And as a clinician, you got to be able to identify sleep apnea. One of the pitfalls of testosterone, you give them the testosterone, they feel more energetic and they feel a greater amount of stamina. They're going to the gym. But after all, I say, Doc, it's not working so well. You got to give me more. You give them more. You're actually making their sleep apnea worse because they're feeling more fatigued. So you got to be keyed into that potential side effect. Polycythemia, an increase in the red blood cells. Sometimes it increases so much, we got to pull blood cells off and we got to send them to Lucy Cursor to get them bled and do a therapeutic phlebotomy. You try and do this with dose moderation. Testosterone can increase oil secretion in the skin. The oily sweat in the armpit makes them smell more manly. Oil on the other parts of the body can cause acne, which is not a pleasant side effect. If your patients are in their 50s or 60s, they already know about the old man peeing symptoms because testosterone makes the prostate larger. Old man peeing symptoms get worse, so that has to be managed. And you get testicular atrophy. So guys get smaller balls, which they hate. You are never going to get around the prostate enlargement or the testicular atrophy. That will happen regardless. So you got to tell them this is going to happen and you got to put up with it. It will also affect their estrogen levels. Testosterone gets converted to estrogen in one step through the aromatase. And believe it or not, we sometimes can manage this with an aromatase inhibitor to decrease the excess levels of estrogen. But you don't want estrogen to go away. Estrogen is important for male libido. It's actually the ratio of testosterone to estrogen is the thing that helps determine male libido. When you do testosterone replacement, sometimes you throw that ratio off. Sometimes the medications you give them are going to get the estrogen level to go down, and that can affect libido. So it's not just testosterone that affects libido, it's the ratio of testosterone to estrogen that affects that. And then the big thing that we worry about is the cardiovascular side effects of testosterone. The good data is that from this trial, the Traverse trial showed that physiologic replacement levels of testosterone have not been shown to increase major adverse cardiovascular events. That was the trial that was done with transdermal testosterone androgel and Axiron were part of this trial. It was supervised by the Mayo Clinic. As far as this was the largest study here, this was a meta-analysis of over 30 trials over 11,000 patients, again with physiologic testosterone replacement therapy, which did not show an increase in major cardiovascular events. And these were the ones they were looking at: stroke, myocardial infarction, all-cause cardiac mortality. You'll take a look and see there the odds ratios all cross one, so there is no significant increased risk in cardiovascular events for that. But we know low testosterone that you see and the low HDL that you commonly see in patients who are not on testosterone replacement therapy, that has been shown to be an adverse cardiovascular risk. However, if you give them supraphysiologic testosterone, or if they are taking on their own supraphysiologic testosterone, this has an adverse suppression of the HDL cholesterol. So when you do testosterone replacement therapy, there is a Goldilocks zone range for the testosterone in which you're having a neutral to beneficial effect on the HDL cholesterol. Too little testosterone, low HDL; too much testosterone, low HDL. So there's a Goldilocks zone range which you're trying to stay in for that. And then a lot of patients, because testosterone is widely available, they may come to you on exogenous testosterone already. If they're already on superphysiologic doses, they're going to come and you're going to see their good cholesterols are sometimes 20 or in the teens range, which would make a cardiologist's head explode. So you got to make sure you moderate the dosage to avoid the suppression of the HDL cholesterol. As far as delivering testosterone, there's all sorts of new methods now. Before there was an oral testosterone, it was methyl testosterone. It was too toxic, so we got rid of it. The buccal patch, no one liked that, so that's not made anymore. The oral testosterone came back as an ultra long-acting testosterone undecanoate, which doesn't have the 17-alpha methylation, so it's not liver toxic. So these are the testosterone methods that we have. But based on insurance, these are the two that you're going to do is the topical or the intramuscular, because these are generic. Everything else is brand name and super expensive, and you're going to hardly be able to use because your insurance is going to force you to use topical or intramuscular. And those are the ones we're going to talk most about because it's the intramuscular that you have to manage the side effects most on. As far as low levels of testosterone for the transdermal, we're going to talk about that first. The patches no longer available because everybody hated the patches, and you can get injection site reaction or application site reaction for the adhesive, so no one uses those anymore. All the transdermals are glycoalcoholic gels that you're going to use that they apply every day, and even though they're now both generic, they're still pretty expensive. So the original androgel, this is the pattern that you see. So those dotted lines, the top one is superphysiologic, the bottom is the low normal level of testosterone. Basically on a transdermal, you will never reach superphysiologic, so you don't have to worry about the problems that you encounter with that. That's where all the problems come from when you get superphysiologic. The better gel, the Axiron, these are the doses there. It gives you a little bit higher dose on there. But again, you never really reach superphysiologic on the transdermals. There's such things as compounded testosterone. Some of the compounding pharmacies can make these, and they can be creams or gels, which can be cheaper than even the generics ones. The factors that affect absorption are going to be the surface area you apply it to. That's why the patches aren't used anymore, because it was too small a surface area. The gels, the larger the surface area you apply it to, the more area for absorption. But it depends on skin thickness, hydration status. And there's a restriction that once you put this on, you don't want to work up a sweat, hop in the pool, or get it wet for at least an hour to allow it to be absorbed. And then the transdermal testosterone will give you a low to a low moderate amount of testosterone. Again, you're never really going to see super physiologic levels on transdermal, so it's safe in that regard. Intramuscular, this is probably the more common one that most of our guys are on because it's the cheapest way. This is the one that causes the least problems with insurance, so most guys are on this, and they get a lot of the very good beneficial effects. But the problem is the drug levels that you get. That's where all the adverse effects come from. This is a difficult to administer thing because it's an intramuscular injection in the butt. I have been HIV positive for 30 years and on testosterone for probably 25 of those 30 years. I have never been able to give myself an intramuscular injection. I cannot harpoon myself with a 1-inch needle. If my husband didn't give it to me, I would never get a single one. So it's a hard thing to administer. It's done either 7 days a week, 10 days, every 7 days, every 10 days, or every 14 days, depending on the half-life of testosterone. There's now an ultra long-acting testosterone that can be done every 12 weeks, which is nice. That's testosterone undecanoate does that. Testosterone are given as testosterone esters, so it's either complex to propionate, a cypionate, or an anthate. And the carbon chains on that ester determines how long that testosterone acts, and I'll give you a slide for that. It's also put in a vehicle, which is usually an oil, so it's sesame seed, castor seed oil, or cottonseed oil. There's now a synthetic, what's called a mixed chain triglyceride oil that's they could administer that into. Um, and because the muscle is more vascular, that's where all the problems come from for the administration. So when you administer testosterone, it's absorbed through two different methods through the muscle. It's dissolved through lymphatic absorption, and it's also absorbed through the blood. So this is more direct than one of the other possible things is because part of it's absorbed through the lymphatics and part of it's absorbed through the blood. When you administer testosterone via intramuscular injection, one of the complications is an oil embolism. A large chunk of the testosterone can get into the vascular system, and they can get what's called an oil embolism. And you might have even seen this in your practice when a patient gets testosterone injection. They have this coughing spasm, like they're coughing really, this coughing paroxysms. It's because that oil got to the lungs. That's what that was an oil embolism. That's much more common with intramuscular. You don't get that with transdermal, and it's much less common with subcutaneous testosterone. So the big thing about the injectable testosterone is absorbed via two pathways, a lymphatic and through the bloodstream. The lymphatic pathway, you actually get an extra bit of a pump from being in the muscle because the muscle acts as a pump to pump more of it into the lymphatic system. You also get some that it's absorbed through the bloodstream. And this is the whole reason why that's important, is because when you take a look at how this works over the time you inject it to, this is 14 days, you see a big superphysiologic bump on the testosterone. That is the source of all the pitfalls with intramuscular testosterone, is you get this superphysiologic peak, then you come down into the physiologic range. And when you get that superphysiologic peak of testosterone, that's when you get all the adverse side effects. That's when you get suppression of the testosterone receptor, because you have a lot of ligand binding to the receptor, you get classic receptor downregulation. If this happens for a long enough period of time, because testosterone receptors are intramuscular, it translates into the nucleus. That affects the transcription of the testosterone receptor itself. So over a long enough period of time, you actually not only downregulate the receptor, you downregulate the number of testosterone receptors. That's why intramuscular testosterone works really well initially, but over months to years, patients say, hey, doc, it's not working well enough. You got to give me more. It's because you've downregulated the receptor and downregulated testosterone receptor transcription. So there's a fewer receptors to receive the signal. And then that gets you in the vicious cycle that you give them more testosterone, you downregulate the testosterone receptor further. So trying to avoid that superphysiologic bump initially, that's the way to avoid some of the pitfalls. And this just shows the ultra long acting testosterone. That the graph on the right is measured up to days, 14 days. The graph on the right is measured up to 56 days. That's 10 weeks. That's the ultra long acting testosterone. So it also gets that bump because there's dual absorption from lymphatics and from the blood, but it actually has a very good prolonged level. And this is what we're talking about the dual actions of absorption for intramuscular testosterone. So on the left is intramuscular testosterone, on the right is subcutaneous testosterone. So in the intramuscular, the size of these arrows give you some idea of how it's absorbed. So it's deposited into the tissue. The testosterone esters then cleaved by tissue esterase, and the testosterone is released into the bloodstream and also into the lymphatic stream, and that gives you an idea. If you do it subcutaneous into the fat, much more of it goes to the lymphatics and much less of it goes to the blood. So when we show you the distribution curves for the for the subcutaneous, it's a much more even testosterone, and you avoid that superphysiologic bump of testosterone initially, and that helps avoid some of the long-term side effects. So in talking about subcutaneous testosterone, it's an easier injection. It's a subcutaneous, like an insulin syringe. And the testosterone, all testosterones can be administered this way, but the only one that is FDA approved right now is Zosted, which is testosterone enanthate. And the unfortunate thing is it's not a high enough level to achieve what we want in most of our patients. And it's an expensive way to replace testosterone. But you could deliver any testosterone ester subcutaneous. It could be testosterone propionate, enanthate, cypionate, even undecanoate can be delivered subcutaneously. And you get a good even transcription. It's not going to be covered by insurance yet. And again, it's a more steady lymphatic uptake, much less from the blood circulation, and there's a much lower risk of pulmonary embolism. And when you take a look at the distribution curves here, you don't see that big bump initially that you do from intramuscular testosterone because there's much less of a blood contribution. It's almost all lymphatic from subcutaneous. So you get a more even level, and then you avoid the problems with that big bump initially in the testosterone level that is super physiologic. This is just long-term administration over many weeks. There's a slight increase over time. And these are the side chains examples. So the fewer carbon side chains there are, the shorter acting the testosterone is. Testosterone propionate, it was dosed twice a week. Testosterone undecanoate with 11 carbon side chain can be dosed every 10 weeks. Okay. And then as far as the more common ones that use cypionate and anthate, cypionate is about every 7 days. Cypionate, I'm sorry, is about every 10 to 14 days you can dose it, but everyone tends to dose it once a week. So you get a little bit higher level and you run into the super physiologic problems. Testosterone anthate really is about every 7-day dosing. So if you can use that one, that works better, but it's a little bit more expensive for some patients. Again, this tells you what side chain, what it looks like, what the release rate is, their half-life, and how approximately often you are going to dose these things. So again, the ultra-long testosterone and undecanoate can be dosed every 10 to 14 weeks. Testosterone propionate, which is never used anymore, you can dose twice a week. There is an injectable implantable testosterone. I'll go through this really quick because no one ever is on this. It's injected subcutaneously. The pellets are under the skin. It's a surgical procedure. They can extrude. It causes infection. I have one patient on this because it's a complicated procedure. So not many people use this. There is an oral testosterone now, long-acting testosterone decanoate. This is measured in 24 hours, so it's a peak and you have to get dosed again another peak. You're not really going to get super physiologic on this, so this is good. But this tells you why you're using transdermal or intramuscular because of the cost. Everything else is really expensive. So it'd be great if you could use the oral or the subcutaneous, but it's sometimes too expensive and you can't get it approved on insurance. So you have to wind up with doing the management issues with the injectable testosterone. So as far as managing the side effect, this is the crux of the talk I want to get to. As far as thinning hair, yeah, you can give them finasteride to try and decrease their thinning hair. But remember, finasteride works by blocking the conversion of testosterone to dihydrotestosterone. Dihydrotestosterone makes us lose our hair, it makes our prostates larger, so that you're blocking that, which is good. But dihydrotestosterone is also the active form of testosterone, which is responsible for libido and muscle mass. So you're blocking that if you put them on finasteride. So it's kind of like stepping on the gas and the brake at the same time if you're using finasteride and testosterone replacement therapy. You can use minoxidil, both topical and oral, to help improve their hair on their head. Tell them they're going to get hair everywhere else too if you put them on minoxidil, which the bears love, so they like that. Excessive increase in libido, yeah, you decrease the dosage, or you change the delivery mechanism because that big bump in that level with intramuscular testosterone, that's what causes the increase in aggression. And if there's no libido, you can increase, no increase in libido, you increase the testosterone level or you change the delivery mechanism. But you also got to look for confounding factors. So again, if they're on 4 different antidepressants, if they're now increasing the testosterone, you're not going to increase the libido that much because we know that major depression, the increase in libido is not as impressive. If they just have symptoms of depression or symptoms of anxiety, those get better. But if they've actually got major depression, you may not improve their libido much. And as far as the big one is cardiovascular side effects. So the big thing is testosterone decreases the HDL cholesterol. And it increases testosterone causes an increase in the activity of lipoprotein lipase, and it changes it decreases the HDL cholesterol. And couple ways to combat this. You want to tell them to take polyunsaturated fats, nuts, olives, avocados, things like that. Deep sea fatty, oily fish can help. You also got to watch out for tachycardia and hypertension. So when you start someone on testosterone, pay attention to what their baseline heart rate is. After they've been on testosterone for a while, if they start to see that their baseline heart rate went from 50, 60 to 70, 80, what this is happening is it's telling you that they're developing some form of diastolic dysfunction. The heart is a muscle, just like any muscle in the body. If you exercise it too much, it's going to get thick. And one of the things that happens when you get a thick, stiff heart is it doesn't stretch as well to fill with blood. If the stroke volume goes down, you remember from your Frank Starling curves, the heart rate has to go up. So when you start to see a heart rate increase in a patient on testosterone replacement, it means they're not getting enough cardiovascular exercise, their heart's getting thick and stiff, and they're getting more diastolic dysfunction, and that may actually show up on an echocardiogram. So dosage reduction is what you want to do. You want to make sure that you're getting some aerobic exercise. You want to assess for secondary polycythemia, because if the red blood cell counts go up, the heart has to work a lot harder to push this thick, sticky blood through the circulatory system, and the heart gets thicker. Medication management is the last thing you want to do because you want to try and address this beforehand, but sometimes you need to use a beta blocker or a calcium channel blocker to slow the heart rate down. Again, you want to address the secondary polycythemia symptoms. If the polycythemia, the increase is not so bad, you can just decrease the dosage, and it will autocorrect in 120 days because red blood cells live about 120 days. But you may need to do a therapeutic phlebotomy, and again, monitor for sleep apnea. And you may need to talk to them about CPAP machines. Okay. Prostate, that's the other big thing that you have to worry about. You're not going to get around this. The prostate's going to enlarge. You can use alpha blockers. Again, if you use a higher dose of finasteride, you are going to inhibit some of the effects of testosterone. So the PDE5 inhibitors, like low-dose LACLS, that works. It has less of an inhibition of their sex drive, and it actually helps with erections. But the insurance wants you to try the other two first before you get there. Or the old man just cut our fluid intake at night, so we don't drink as much at our cocktail parties. And then you want to minimize the use of medications which increase the bladder sphincter, like pseudoephedrine, alpha blockers like midodrine, or inhaled ones like their asthma medications, and duloxetine, which is sometimes used for pain management. That also tightens the bladder sphincter. For elevated PSAs, you follow the American Urologic Guideline criteria for monitoring the PSA. But remember, if they have an elevated PSA, you just repeat it the first thing, because trauma, especially if they're having more sex now that they're on testosterone, if they're getting sexual activity and trauma on their prostate, that can cause the PSA to go up. So you just repeat it. If the PSA goes down, it's more reassured. But if you get this spiking elevation, you can just follow them. But if the baseline PSA from the spikes is going up, then you may need to get an MRI. And then you follow what's called the PIRADS criteria from the prostate imaging reporting data. PIRADS level 1 or 2 lesion on an MRI, less than a 50% chance of cancer. A PIRADS level 3, 50-50, right in the middle. But if they're a 4 or 5, that's when you make the urology consult for a prostate biopsy. And fortunately, if you have an MRI, you now have a map, and they can do a robotically assisted prostate biopsy, so they know exactly where to go. And let me just optimize efficiency. This is the last slide, was just to go over that. So I actually got through it. Okay. Questions at the end.